Hi, my name's Sue Mallett. Welcome to this short course on designing diagnostic test accuracy studies, the absolute essentials you need to know. I work at the Centre for Medical Imaging at UCL in London in the UK, and I'm going to share with you important tips I've learned in designing these studies across the last 20 years. The Introduction to Diagnostic Accuracy is a series of short videos, each highlighting a key learning point. This is video part 3, and we're looking at the outcomes used to summarise test accuracy results. In this video, you're going to see that different diagnostic studies can have really different aims, and that means that the data is presented really differently. Sort of starting off studies are ones where you're in the lab and you've got a sample and you put it into a dish and you're getting a colour change. And the aim of these studies is often just to understand the test. These are very early phase studies, they're experimental, you're just developing the test at this point. And so when you look at the results, you're interested in seeing the spread of results in people without the disease and people with the disease, and you'd want those to be different. This is a nicer graph. I like this sort of graph more, where you can actually see the individual data. These are all people without the disease, all their test results for the CA125, and here's the people with disease, and again you can see the individual results. Each of these dots is an individual patient with their results are from the CA125 blood test. Okay, and then these results, you can look at them at a different series of different thresholds, and you can work out the percentage of people with disease that you detect at a particular threshold and the percentage of people without disease that you detect at a particular threshold. And you get this thing that we call a ROC plot. And here you can see all these different thresholds for deciding what's a positive test result. And there you're getting the what we call the sensitivity and the 1 minus specificity at those different thresholds. We'll come on to sensitivity and specificity during this video. Okay, so those are the really early studies when you're just developing the test. When you've actually got a test and you've now got a little bit more of a sophisticated piece of equipment, you're still in the lab developing this test, but you're actually now looking to see if you can develop a test that's more reproducible. And you're still trying to explain the results, but you're trying to look more at the reproducibility of the results. And here you're going to have things like a Bland-Altman plot, where you're comparing the difference between two different results on the same patient sample compared to the mean of those. And here's a nice Bland-Altman. Each dot is for a sample. A patient that's tested at 2 different time points, 2 different samples. And here you might do a correlation between the results taken at 2 different time points here. The Bland-Altman gives you quite a bit more information than the correlation. And maybe in a video we'll talk about that. So you're getting results, things like a comparison of the results between within an observer and between observers. You're getting things like ICC, Bland-Altman, all these sort of things. So you're just basically looking at the reliability of the test results in this analytical early phase study. Okay, but as you get into late stage studies where you're actually recruiting actual patients. You've got a protocol, you've got a statistical analysis plan, you're recruiting the patients, you're hoping your result is really going to help you with a particular clinical pathway, testing in a particular clinical pathway for a particular disease, and you want to inform guidelines. And this is when you're in that clinical phase, the pragmatic phase. And the aim of these studies is to make clinical decisions with the tests. And that's when we get onto these 2x2 table of test results. And here we have our reference standard that we met in the first video, and which is your truth about your best guess at what the truth is as to whether someone's got the disease. And here's the index test, which is your new test you're trying to look at. And here we have 100 people who have the disease with the reference test, and we found that 90 of them are also positive with our index test and 10 are negative. So these are false negatives, these are true positives. Okay, and then we've also recruited 300 people without the disease in this study, and what we can find is 240 of those also have a negative test result. That's correct. So they get a correct result from the index test saying they don't have the disease. But we've got some false positives. We've got 60 false positives. Okay, so in these clinical phase studies, you've actually got a flow of patients going through the study. You've got the patients being recruited. They get first the index test, then the reference test. Then you can do this 2x2 table of results of the reference test results against the index test. And this is where you can actually see that when they get the same result, that the disease is present with both the reference test and the index test, those are true results, true positives. If the set of patients who get a negative test result with the reference test, so they don't have the disease, and they get a negative with the index test, those are true negatives. But we also can have false positives, where people without the disease by the reference test get a positive index test result. We can have false negatives, people who really do have the disease determined by the reference standard, but they don't have a positive test result with our index test. Okay, and we can use these results in the 2x2 table to make different summary measures of accuracy. One of those is sensitivity, which is the proportion of people with the disease that are picked up by the test. So these are disease positive as defined by the reference standard. So the proportion of those that we pick up with our index test, that's 90 over a total of 100 people with the disease. So sensitivity is 90 over 100 or 0.9 or 90%. You can express sensitivity as either a proportion or as a percentage. Okay, and there's a second outcome, which is for the disease negative people, and that's called specificity, and what proportion of people, disease negative people, are correct with the test. Okay, so the ones that are correct with the test result are the ones who don't have a positive test, they have a test negative result, and the proportion of those that are negative, of the people without disease that are negative with the index test. So that's 240 over 300, which is 0.8 or 80%. Okay, so notice that when you're looking at diagnostic test accuracy using sensitivity and specificity, these are completely independent numbers from completely independent sets of people in the 2x2 table. Now, everyone in that 2x2 table needs to come from a single set of patients. Okay, but then we express the ability of the index test to pick up the people with and without disease by two different measures, sensitivity and specificity. And these are useful for understanding at a population level what the impact of the test, and these are used for health service planning. I'd also let you know that it's easier to calculate sample sizes using sensitivity and specificity. It's easier to do meta-analysis and 95% confidence intervals as well. So these are quite often the measures that we use. There's an alternative set of measures called PPV and NPV. So PPV is a proportion of positive test results from people with disease. Okay, so all of these people have an indexed positive test result, and 90 out of 160 of them, or 60%, or 0.6, a proportion of 0.6, of the people with a positive test result actually have disease. The paired result that you need if you're going to use PPV is NPV. So this is a negative predictive value. So what proportion of the negative test results are from people without disease? And again, what you're going to do is you're going to take, these are the people with index test negative result who don't have disease, and you express those as a percentage or a proportion over the total number of people where the index test result is negative. Okay, so 240 over 250, or 0.96 or 96% of negative predictive value. Okay, PPV and NPV are often helpful for interpreting results in individual patients. So if you've got a positive result, what's the chance you've got the disease? Here, 60% chance of having the disease, a good chance of not having the disease, even though you've got a positive result with this test. But if you've got a negative result with the test, you've got a very high chance that you haven't got the disease. Okay? And the sample size calculations and 95% confidence intervals are much harder with these PPV and NPV, and that's because often patients end up being counted more than once within the proportion. There's a great video here from Grant Sanderson, which I'd recommend, and that's really helpful for thinking about PPV and NPV. So thank you very much. That was part 3, where we were looking at the outcomes used to summarise test accuracy results. The next video is part 4, which is about cross-section and cohort studies. See you there.